I want to answer all the questions during the session. However, due to our time constraints, I might not be able to answer all of them live. Those that I do not address will be answered in email to all the webinar participants, so make sure that you have provided an email address. And again, this is part of a series, so for additional information on some of the basics and installation that we covered last time, please refer to the Forces for Beginners webinar, and that's viewable on the 3M website. Along with additional sources of information that are on that site, there's also upcoming courses that I'd like to share with you. Dr. William Vogt and I will be in Newport, Rhode Island on September the 23rd through the 24th with a Forces Users Meeting. Dr. Vogt was involved with the development of the appliance along with the 3M engineer, so he's got an awful lot of experience in clinical knowledge that I'm sure you'd appreciate hearing as well. I'd like to ask a question of the participants, and that question is, what is the most commonly used appliance in your office to correct Class 2 deep bite malocclusions? Is it a Forces appliance? Is it Class 2 elastics, headgear, or distalization appliances? Here are the results of that poll, with Class 2 elastics and Forces being most commonly used. And we're going to talk about some of the advantages that Forces has over Class 2 elastics as we go through our cases. Now, when we're using the Forces, it can be effective in Class 2 cases, and if the deep bite is coming from a maxillary origin, cases that have a vertical maxillary excess, or if cases that are Class 2 with a deep bite and it's coming from the mandibular origin. There's just some slight modifications to how we install the appliance that we'll really go through today as we look at those. Its efficiency in Class 2 correction. We've talked about this before. Part of a Forces appliance, its efficiency has to do with how it's independent of compliance. You don't have to rely on patient cooperation. It's also very easy to install, it's easy to adjust, and patients really adapt to the appliance well. But when we're talking about certain types of Class 2 correction, there's an increased efficiency. And this is something that it took me a while to really appreciate until we have had more experience with the appliance. And I really like to share this because I think this is where it really becomes efficient and enjoyable. If you're looking at using Class 2 elastics to correct a malocclusion, often we think that we have to level and align the arches. So we coordinate our arches in a transverse dimension, we completely level the curve of SPE, and then we start our Class 2 correction. And I think you've experienced clinically in some cases that are very deep, this leveling of the arches can take considerable amount of time, and then you're attempting a Class 2 correction after the patient has been in appliances for a while, so it can extend treatment time. But the nice thing when you're using a Forces appliance is we don't have to level the maxillary and mandibular arches before we place the appliance. We actually just need to coordinate the transverse dimension of the appliances first. That was saying that what I mean is we need to make sure that the maxillary transverse dimension is coordinated with the mandibular transverse dimension so that when we go to place the appliance and are going into that Class 1 position, that we have enough maxillary transverse dimension to accommodate that new mandibular position. So bite opening we're going to accomplish with our Forces in place. If we need to open the bite through the mandibular arch or the maxillary arch, we can do both of that with Forces in place, and I'll explain to you how we go about that. The nice thing about it is the vectors that are associated with Forces also enhance that bite opening mechanics, and we'll take a look at that. You may remember this slide from the previous webinar, and if we take a look at what kind of Forces are involved here, let's concentrate on the lower mandibular arch, because if we're looking at trying to level the mandibular arch and we're trying to intrude lower incisors, Now, I mentioned before, if we're going to be using class 2 elastics, you're going to accomplish that, before you start trying to accommodate a new mandibular position. But what happens if we're using a forces appliance? Well, if we look at where those forces are applied, in the mandibular arch, there's the mesial, and there's also an intrusive component. So this component here can really maximize the amount of bite opening that we can achieve through intrusion of lower incisors, and we'll show you how we maximize that in cases. So what about bite opening in the maxillary arch? Well, I apologize, our arch wire moved. It's supposed to be right there, and that's our arch wire. I apologize for that. Let's think about bite opening in the maxillary arch. If we don't have a forces in place and we start trying to intrude upper incisors, you maybe put a curved arch in or some type of a bite opening intrusive arch wire, it tries to intrude the maxillary incisors. But at the same time, remember, if you've got an intrusive force in the anterior region, you have to have a counter or extrusive force in the posterior region that you're seeing here. So as you're trying to intrude maxillary incisors, the posterior teeth are counteracting, they're trying to extrude. Well, what happens if we can hold that in place? And what I mean by that is if I put an intrusion arch in the maxillary arch, place of forces, this arrow here, which is that component associated with the forces, can counteract that force. So what happens is I can see a lot of maxillary incisor intrusion and not a lot of posterior extrusion. I can control that. So it becomes very efficient in trying to intrude maxillary incisors as we retract. And it's pretty exciting. I'll show you some cases we've had a lot of fun with. So let's talk about, let's start with the mandibular arch. And we're just going to basically start with a basic case. We've got a class 2 malocclusion, there's mild to moderate deep bite, and it's of the mandibular origin. I'm just going to use my standard forces setup, and that's what we talked about last time. We're going to have a 19 by 25 arch in the top. It can be beta, it can be stainless, it can be nickel titanium. The mandibular arch, though, remember, that has to be a more rigid arch, and we're going to want to place a beta or stainless steel arch. We're going to attach the forces spring in an occlusal tube, and we're going to go for an ideal activation. So this is really what that standard setup looks like. As I've turned that maxillary arch wire, because I really am not using it as a distalization appliance now, I'm going for a class 2 correction. I've got my lower arch in place, and here I am at the first bicuspid. Again, you can use the cuspid location if you want, the first bicuspid location. But remember, and if you look at the spring setup here, you can see that you've got some vertical component there. Obviously you've got the horizontal component that's going to be working on the class 2 correction, but here we've got some vertical component that's going to help us intrude those lower incisors. So on a young lady like this here, that we're just a mild class 2 and just a mild deep bite, all we really need to do is get into that lower rigid arch wire. Again, we don't have to worry that our mandibular occlusal plane is leveled. That's going to happen with our forces in place. The only thing we do need to make sure is that we have got enough transverse dimension on the top to accommodate that mandibular, the mandible coming forward with our forces in place. So if we look from our cephalometric film here, again, we've got the AP correction we want to attempt. We want to intrude her lower incisors and really maintain that upper incisor position. Here we are, just the finished case using that standard protocol, basically aligning the arches to get into a rigid mandibular arch wire, placing that forces with the ideal activation and getting to this ideal position, maintaining the maxillary incisor position, but intruding the lowers. So when we take a look at our cephalometric film, that's what we see happening. And I'll show you too with some retention photos. You can see that the depth of bite, the bite opening is holding. And again, that's our retention film. So with your mild depth of bite, it's coming from mandibular origin. Basically, your forces is going to open your bite for you. You're not going to have to worry about that. Now, let's talk about something that gets a little bit a little bit different, a little bit trickier here. You know, let me take a look. There's a bunch of questions coming in. So let me just answer a couple of these here. This is an interesting one. What do you think about placing forces on upper second molars and lower first premolars? Lower first premolar, I use that option a lot. Upper second molars, I have tried that before. The only thing you really need to watch there is that when a patient is functioning and opening and closing, really where the coronoid process of the mandible is at. When I've tried that before, they actually could catch, it would interfere with mandibular functioning. So I don't use that. One thing I do use, though, is deciduous second molars in someone that access may be a problem. We're talking about, there's a couple questions about retention, and we will get to that. Another question, what about that first bicuspid versus the cuspid for the vertical nature? If you've got a patient that we really want to see more of a vertical component, you can go to the force. And actually, let me hold this question, because as we go through other cases, I'll show you where you may want to attach to the cuspid to get that vertical component closer to the anterior. So that first case we looked at was obviously just an easy set it up, let the forces do its work for you. Now let's get a little bit more interesting. What about in a case where there's a class 2 with a moderate to severe deep bite? And I think I probably need to go back. Remember, when you look at a case that's class 2 and they're deep, one of the first things you have to decide is where is it coming from? Is it coming from the maxillary incisors? Is it coming from the mandibular incisors? You know, for me, the easy test is have the patient smile at you. If you like their maxillary incisors, we're going to do everything we can not to intrude those. So these kids that you're looking at here are all kids, when you look at them, you like their maxillary incisor display. We want to really work at opening their bite through mandibular incisor intrusion. So let's go on and take a look at this patient here. Here's a good example of that. If you take a look, here's patient 1, and you can see the depth of bite. I think we'd all agree that we've got a deep bite. We've got a class 2 relationship. We're going to need some torque on those maxillary incisors, because remember, that's important. You know, when I talk about opening the bite with forces in place, you definitely can do that. But remember, you're going to have the right torque on your maxillary incisors to start. So if you start trying to bring the mandibular arch forward now, there's really no clearance with those maxillary incisors. But let's compare patient 1 to patient 2. You know, there's some similarities to this patient here. They're deep as well. A class 2 relationship on that left side, really a kind of a class 1, definitely a class 1 on the right side. But I think what's interesting when you look at both of these patients, if you compare them, you know, real similar occlusions on that left side. But let's look at them further. I think when we look at the cephalometric films, everyone agrees these are two different faces. We've got patient 1, even though she's got a deep bite, we know we need torque on those maxillary incisors to be able to accommodate a new mandibular position. And she really has an ideal facial height, ideal facial proportions if you're looking at, you know, middle third to lower third. Now, if we look at patient 2, when we looked at him, he had a deep bite as well. But I think you can see that difference in the decreased lower face height. So there's some things we're going to do different between both of these patients. And again, facially, see there's a bit of a difference when we're comparing lower face heights. So how are we going to do this? You know, this is all talking about manipulating that mandibular occlusal plane, and this is something that's different, particularly for if you're not used to using forces or use a lot of class 2 elastics. There's options that exist with forces that don't exist when you're using those class 2 elastics. We can level the mandibular occlusal plane through lower incisor intrusion, and it's aided by the vertical force of the push rod. And that was really that first slide I was showing you, where there's that vertical component, the mandibular arch from the push rod. And we want to intrude those lower incisors. And when we intrude lower incisors, part of our goal is to open the bite, intrude the lower incisors, maintain the maxillary incisor position, and basically maintain that lower face height, maintain the posterior vertical dimension. And that would be like the young lady we saw, that's patient 1. Now in patient 2, we've got an option. we can level the mandibular occlusal plane through posterior extrusion. That's something that if you're trying to do that with class 2 elastics, you really can't because your teeth are in contact. When you place the forces, there can be a component of disarticulation of the mandibular posterior teeth. And what that allows us to do is really extrude posterior teeth. We can increase lower face height and increase posterior vertical dimension. And that is something that we'd like to do in patient number 2. Because remember, we had the decreased lower face height, and we want to increase that for aesthetics. So what are the protocol? Let's talk about patient 1. We're going to use an occlusal tube, and we're going to put the spring module attachment. You can use an L pin, you can use an easy module, but go in that occlusal tube of your band. And if you need to reference this, go back to the first webinar. And there's no need to open that bite before that forces placement. But what you're going to do is when you put your mandibular arch wire in, if you want to help intrude lower incisors, you've got the push rod pushing for you, but you really want to intrude those lower incisors before you put that rigid arch wire in. If it's beta or if it's stainless, sweep some curve into that lower arch. So just a bite opening curve and then place it. So now you're really adding the two. You're adding the push of the forces rod, and you're also adding the intrusive force of the wire. So they act in synergy really to intrude those lower incisors for you. So if we look, diagrammatically, what does that look like? Again, we want to maintain that lower face height. We basically want our lower incisors to come down, and we want to maintain that maxillary incisor position. So when we take a look at this situation here, we've seen her before with patient 1. This is what she'll look like when her force is in place. Excuse me, let me go back here for a second. Again, we just really had to get the torque in the maxillary incisors. Then we place our forces. We put that bite opening curve in. And what's happening as our forces are in place, this is what it should look like for you. And if we compare that to what we're going to see later on, you'll notice that the teeth, her posterior teeth, are pretty much in contact with one another. And that bite opening is coming from the push of the rod combined with that curve that you put, that reverse curve that you put in the mandibular arch. And your forces will open that for you. So here we are with the forces in place. And you'll see a difference compared to patient 2. But this really is what that setup would look like. And that's where the bite will open for you. And if we look at our cephalometric film, we're able to see that we were able to maintain or to establish the torque, placed our forces, placed that curve into the forces, and then removed it after we were in a class 1 relationship. And if we look at our superimpositions, that's what occurred. And again, you do have to establish the maxillary incisor torque first, and then we're bringing our lower incisors and mandibular in place. And we want to really do minimal changes in that profile. And if we look at our superimposition, we maintain that posterior vertical dimension. If we look at where the molars are at, we can see where our incisors have come forward and the torque on the maxillary incisors as well. And our finished profile and finished occlusion. Now, let's go on to patient 2 in the options. Now, what about leveling that mandibular occlusal plane through posterior extrusion? And people that are used to using other types of fixed class 2 correction appliances are very familiar with this, so it might not be new to them. But it was kind of a new idea for me as I was becoming more experienced in using the appliance, and it's become really helpful. Now, if we look at this diagram here, we want to increase that posterior face height. Remember in patient number 2 where he had that decreased lower face height, we wanted to increase it as we open the bite. We are going to get some lower incisor intrusion just from the push rod. But what it's going to look like, we've got that deep curve of speed. Don't worry about leveling it. Just get into that arch. If we want the lower incisors to come down some, sweep the curve in like we did with patient 1. But what's going to happen is when you bring a lower arch forward and there's a deep curve of speed, when you slide that forward, you're going to see a posterior open bite. And often people will ask me, well, my forces created an open bite in the posterior. That's not really true. Remember, that curve was still there. You're just bringing it forward with that arch still curved. You're going to do this part later, and I'll show you what that's going to look like. We can combine those. You are going to see some lower incisor intrusion because you've got the push rod pushing these down, but you still are going to see a posterior open bite, and that's okay. We're going to take care of that afterward using some posterior vertical elastics. So let's take a look at patient 2 and what's going to happen when we place his forces. We've got that deep curve of SPE. It's still going to be there when we place our forces. We're going to go again with occlusal tubes, because remember, when you're in an occlusal tube, you can use an L-pin, you can use an Easy 2 module. That's going to give you that horizontal component that you need. The rod's going to give you some vertical. But let's take a look at when you put forces in a patient like this. Here's his pre-forces Ceph, and you'll notice we're still deep. We really got the torque and the maxillary incisors where we wanted it. We wanted to watch that we didn't intrude those maxillary incisors. I think sometimes it's so tempting when someone's deep to get bite opening through the maxillary arch because it's easier. But aesthetically, a lot of times that's not what we want. So let's maintain that position. We're going to place our forces in. We still have that deep curve. And what's it going to look like? Yep, this is what it looks like. We've got that the class 2 relationship is corrected. We've got a class 1 molar, but notice how we're open in the posterior. Again, that is something that is really common, that if you're trying to increase that lower face height, and I think it's interesting, if you look at cephalometrically, I think we'd all agree that we like that lower face height better. It's a more aesthetic profile for this young man. Now, what do I do when I get to this point? If I've got a I've got a posterior open bite, I kind of left it there. I didn't create it. It was there from before. What I will do is I will remove my forces appliance. When we take the forces appliance out, we need to put a flexible arch wire in there. For us, we're in an 022 slot, so I'll go to a 17 by 25. And what I'll do with that 17 by 25, it'll be 17 by 25 nickel titanium. At that point, we're just going to wear some elastics in a configuration. So, here we are diagrammatically talking about that posterior open bite. And we take that forces out. You can see now we put a flexible thin wire in the bottom. Remember, keep the rigid wire in the top because we want to maintain this occlusal plane. This occlusal plane is where we want it. This is the one we want to alter. And you can still see the dip in that mandibular wire. And all we really need to do is move those teeth up that position. So if we've got a flexible wire in the bottom, a rigid wire in the top, and we run our box elastics, it's going to bring those up in position. And a lot of times we'll even have them, if it's a significant amount of opening, we'll have them wear it all the time or just at night. Something you'll find if you have a patient that when they come back just doesn't wear those elastics, we may even take that real flexible wire and just go underneath the brackets, and that will push it up for us. And that's how we finished his occlusion. Now remember, if you've got someone, he was deep but not extremely deep, so we saw a little bit of an open bite. But if they're significantly deep, you're going to see even more. But I think if you compare the lower face height and the profile change, I think we like that much better than just trying to intrude upper incisors or intrude lower incisors and bring them straight forward. And there we are. If we look at if we overlay just the mandible, we can see where we ended up incisor position-wise, but you can see that extrusion of those posterior molars and where we're at. And again, that happens all after the forces is removed. This is someone that has a much more significant deep bite. You can see how deep we are. This is the pre-forces Ceph in this patient. We're going to go into our forces appliance still with that deep curve and the lower arch. So you can imagine when that curved lower arch starts to come forward, look how open we are in the posterior. And if you're not thinking about it, you'll think that your forces did that. But no, it was there to start with, and we're going to take care of that later. You may notice here too, see how that forces rod is all the way forward on this young man? That's at his cuspid. Part of it, he was so incredibly deep. If you look back, we needed to combine two. We needed to intrude lower incisors and extrude posterior molars for our final occlusion. So in that situation, you put your lower arch in, put a little curve into it, put your push rod all the way forward, so you're putting more the force is more closer to those incisors, the vertical component. And then also, make sure your spring is laying vertically. You don't want it horizontal to help accentuate that. But you're going to close that open bite. And I'll be honest, it can look kind of scary the first time you see it, if you don't think, where did that come from? And you think that you created it. But you didn't. It was there, because look at that. See how deep he was? Slide that forward. You can see that arch is still curved, but you know what's going to happen? You're going to take the forces out. You're going to put a thinner wire, keep your rigid wire in the top. You're going to run some class 2 elastics, and guess what? It's going to close up there for you. But again, you got to put a thin wire or a flexible wire in the bottom, or it won't close. So keep that in mind. So here's an interesting question. How do you maintain that curve of speed while using a 19 by 25 stainless in your forces? A lot of times too, if I still have that deep curve of speed, I might not be going completely into a stainless. I may be choosing to use a beta wire because it's a lot more flexible. Keep in mind, for that lower arch, you can use a beta wire. Don't run it off a nine tie. It's going to be too flexible. And then you are going to see an open bite in the posterior from the rod pushing. But if you try a beta in a situation like that, even though you have still some curve in it, you'll be able to slide it in. And again, that stainless steel may be a little bit snug, but I think really the main point is don't concentrate on having to intrude those lower incisors, because you can waste a lot of time. If you're trying to intrude lower incisors, just an arch wire, and someone who's really deep, it can be very difficult and time consuming. As long as you can get the wire in, use the forces to help push it, or use the disarticulation to help extrude the posteriors later. Here's another great question. Do you position the brackets differently on the lower arch specifically to maintain the curve of speed? No, usually I don't. Do I want to go more gingival on the anterior? Usually what I like to do if I'm placing brackets, I'll start on the maxillary arch first, because if I want to maintain that maxillary incisor position, I'll go mid-crown. If I want to extrude them, I'll go gingival. If I want to intrude them, I'll go incisal. So I really kind of have to base it on where that maxillary, if the maxillary is mid-crown, a lot of times too, I will just stay mid-crown. Or, if they're deep and I want to intrude the lower incisors, go a little incisal with them. A lot of times I think the tendency is, if you've got someone with a deep bite, you tend to want to go gingival to keep them out of the occlusion. But a lot of times if someone is deep and you want to intrude those lower incisors, go more incisal. And that'll help. You don't have to really intentionally maintain the curve of speed. Some of the questions that I'm seeing is like, well, how do you maintain the curve of speed? You're not really trying to maintain it. You just don't have to worry about eliminating it. And I think there's a big difference there. Put your brackets where you would for any of your class 2 cases, like the mechanics that you're using now, but you don't have to concentrate on intruding those lower incisors. Kind of be an aid. Because before I'd waste a lot of time intruding lower incisors. Then when I got the ideal depth to my bite, then I'd start my class 2 correction, and I was already maybe 12, 14 months into a case. So you don't really have to focus on maintaining that curve of speed, but knowing you can eliminating and using the forces to help you. So what we've looked at before, if you've got just a normal class 2, they're a little bit deep, just set your forces up normally, because that rod alone is going to help intrude. Remember, once you have that rod, if you're not, I need a little more bite opening, don't be afraid to move the rod to the cuspid. Or once you get it where you want it, move it back. You're allowed to move pieces, and I think that's what's fun about the appliance, is that you've got that flexibility. So if I've got a patient, they're deep, it's the mandibular arch I'm going after. If they're just pretty standard, I'm just going to put their forces in and let it happen. If they're moderate to severely deep, then there's some decisions I need to make. Do I want to open that arch in the bottom through lower incisor intrusion? Do I want to open that, do I want to level that mandibular arch through posterior extrusion? Or do I want to do a combination? And really once you make that choice, it becomes simple. If I want to intrude lower incisors and I don't think my rod is going to do it, sweep a little curve into it. If I want to extrude posterior teeth, I just have to remember that since that curve is in there, the rod's going to push down a little bit, but what'll happen is I'm going to see that open bite, and I realize that I'm going to do the class 2 correction. Don't worry about the posterior open bite. Take out the forces, go into my thin arch, and run some box elastics. And I think when you try it, it really is, it's really efficient, and it's fun. Sorry. Anyhow, let's keep going. So we've got someone who's deep now, but we've decided it's coming from the maxilla. It's the maxillary teeth. What are we going to do about that? Again, we can accomplish maxillary incisor intrusion with our forces in place. And obviously, that you can do that with arch wires even without forces in place. But think back to the very beginning when we looked at that first diagram. If you just stick an intrusion arch in or a night tie that's got a bite opening curve into it, as it's trying to intrude those upper incisors, those posterior teeth are trying to extrude. So you don't get just intrusion, you also get some posterior extrusion. Because remember, wherever there's a force, there's an equal and opposite force working against us in a different location. So I like to think about it, if I want to maximize maxillary incisor intrusion, I'll put my forces in when I'm intruding. Because remember, in the posterior molar, it's pushing up. So that posterior segment can't drop down. So those two eliminate one another. So let's talk about how we're going to intrude that. And again, I'm not sure how this would... Actually, I did look at this before, and I don't know how this is moved. But this little arch wire is supposed to be an intrusion arch wire, and obviously I would put it in the front here. So what happens is we place that arch, and this is what I was trying to describe. We're intruding in the anterior, extruding in the posterior, but that force is right here. These two, this vertical component on that force is going to help maintain that and eliminate that posterior extrusive force. Now, something else we also need to take a look at. This arrow here, what is that talking about? Well, for a lot of you guys that have used a lot of forces, you'll know that when you place the forces in, there's kind of a rotational component of that whole, I'm trying to use my hands so you guys didn't see that at all. The whole system wants to rotate in that direction. But if we put a curved arch in the top, it's trying to rotate in that direction. So really, it's fun when you intrude. Not only does it help intrude the upper incisors because you negate that in the posterior, it also will help you maintain that maxillary incisor position because you're not going to lose the torque that you sometimes can see from the rotational component when you're looking at forces as an entire system. And I have to quit using my hands because you can't see that part. Again, this isn't to confuse people, but some people that use the forces a lot will understand or know that there's that rotational component of that entire system, and this curved arch wire helps counteract that. So let's take a look at some cases. Let's look at this young lady, and if any of you joined me at the AAO, you'll recognize her. But she's really a fun example that is really relatively deep. I also think that we'd agree that she's got a vertical maxillary excess. And if you go back and look at how deep she is, we want to try to accomplish as much of the bite open through maxillary intrusion. You know, we want to minimize the mandibular incisor intrusion because if we can really maximize, we can really make a significant difference in the aesthetics of this young lady. So if I were to go in and just put a reverse curve, or an accentuated curve arch wire or some type of intrusion arch, I might not be able to get her as high as I want to get her to be. So I'm just going to use my forces set up, and I'll show you what's going to happen. Oh, let's go back to her set for a second. again, here's that torque issue. You got to get the maxillary incisors in position first. And we want to try to do that without opening the bite. It's not what's going to happen. Just, when you put that rectangular arch wire and you're going to see some bite opening. But I don't have to concentrate on it. I don't have to open it all the way up. Some of it's going to happen just when you start to put rectangular arch wires in with that rotational component as the torque is expressed. So let's take a look at how we're going to do this. Now, obviously, it's a mild class 2, but we've got that deep bite. This is the part we want to concentrate on. How far can we get her to intrude? And she's slightly retrognathic. So, again, forces is a good choice for this young lady because we can take care of all those at the same time. It's going to correct that class 2 malocclusion. It's going to allow us to intrude those incisors and reduce that gingival display as we're going for the AP correction. Here's the difference. We're going to work up into a rigid mandibular arch wire. 19 by 25 beta, 19 by 25 stainless. Oh, and I should probably figured it out. I'm in an 022 slot. Obviously, if you're in an 18 slot, you're looking at more of a 17 by 25. But here's the difference. You're going to start to intrude those incisors intentionally with that forces in place. With this young lady, you simply go ahead and here we are. We're aligned to it. Ready to place our forces. You can see we still have our deep bite, and we're going to want to intrude those incisors. So when you place her forces, what we're going to want to do is go ahead and put a curved arch wire in. And this young lady, we just used I apologize, say reverse curve NiTi because that's what it says on the box when you order it, but it's actually an accentuated curve in the maxillary arch. So instead of putting a straight 19 by 25 in, I'll put a curved 19 by 25 NiTi in. We'll secure that so the entire arch acts as a unit. So we'll either be turning it like I showed in the very beginning slide with an ideal a setup for this type of situation, or even just chaining it. But I think you get an idea of see where the bite opening came from. And again, it was really easy to accomplish. If we look at some superimpositions, and I apologize for all the colors, but I'll show you what they're trying to show you. If you look here at the black, that was our initial incisor position. We established the torque where we wanted it, and then we can see in the red here, that's where the intrusion came from, and that's where green was pre-forces, and this obviously was post-forces. So it gives you an idea of really where those maxillary movements came from. And then we look at this young lady. Obviously, we did some gingival recontouring afterwards, but I think when we look at her from a facial standpoint, we can see there's a significant difference. If we just take a look at where we're at, there's our profile change. Here's our facial change, and that's where we ended up. So it really made incisor intrusion easy by simply putting our forces in putting a maxillary intrusion arch. With her was a 19 by 25 NiTi, and that's probably really pretty common for us if we have an arch that is that we want to maintain as a unit, that we're not going to be doing any sliding on. We'll place that arch wire. Now this is a little bit of a different situation. Here we're maxillary protrusive and we have a deep bite. Again, we see that we've got a vertical maxillary excess. We also have some spacing in the maxillary arch. And if we take a look at Kimmy here from a cephalometric standpoint, she's about 16 years old at this point, but we really want to use her forces to intrude those maxillary incisors and retract them at the same time. So similar to the last young lady, we're going to concentrate on incisor intrusion with our forces in place. But because we need to slide posterior, we're going to make a little bit of an adjustment in there, and I'll show you what I mean here. We've got that deep bite, we've got the vertical maxillary excess, and we've got those protrusive maxillary incisors. We'll correct that class 2 malocclusion. We're going to intrude and reduce gingival display, and we're going to retract at the same time. So let me show you. What we're going to want to do when we place our forces here in this patient, we're going to put a maxillary 19 by 25 stainless steel, and then we're going to post it. And what those posts are going to do then is hold some NiTi coils for us. And when we have it in place, I'll show you what it looks like. Here we are at our initial. Here we are pre-forces. We still have our spacing. We're still deep. And yeah, there you can see them right there. What at this point here, We were at 7 months pre-treatment. We placed our forces, and this is 3 months later. So in this young lady, we put our stainless steel arch in. We put our bite opening, just swept that bite opening curve into the upper incisors. We had that wire pre-post, and if you look real close, I apologize, it's hard to see, but you'll see there's 2 posts there. From the post to the molar is where we placed a nickel titanium coil. And what that did is that retracted them. You know, the last lady we looked at, we liked the arch, so we consolidated it and just put our curved niti in there and kept it chained together, returned. This young lady, we needed to slide posterior. So if we look at the setup, it's really kind of fun because there's a couple things going on. You've got the reverse, you've got that curved arch that's intruding those incisors, and the forces in that situation, as we're intruding in the anterior, the forces is negating the extrusive force that you'd see in the posterior, but forces is doing a couple other things for us at this point. When we hook up that niti coil, we're trying to retract those maxillary incisors, and what happens when you try to retract maxillary incisors, then the maxillary molars want to come forward. You know, it's a case where you'd really want a headgear. I don't like to use headgears because at least my patients don't like to wear them, so we sometimes would struggle with that. So what's happening here is not only is it helping with our incisor intrusion, it's also helping with incisor retraction, because the molar right here is acting to, or the forces on the molar is acting to hold the molar in place. So the molar stays in place and her upper front teeth retract. Again, just really an efficient system to intrude and retract at the same time and not lose your anchorage, and really to have it happen really pretty quickly for you. And there we are with our final results for Kim. And if we look cephalometrically, we really wanted to intrude and retract. And I think it's interesting to look too, because even though you've retracted quite a bit, you really don't have to worry about too much torque loss there, because again, so many of the forces that we're placing in the maxillary arch are in the posterior from forces. A lot of times if you start trying to go after this type of overjet with a class 2 elastic, you really start to struggle with anterior torque. If you're trying to intrude and retract at the same time, plus you also have an elastic hanging there, it kind of works against you. So if you think about this type of setup, you've got your forces that's going to hold that molar, you've got the curve that's going to intrude, you've got those nickel titanium springs retracting, and honestly it's a very simple way to take care of a situation like this, and particularly in a patient that would be unable to even comply. And even if they did comply with elastics, it's just way too hard to do it that way. This way is just so much easier, and we can look at the amount of retraction and intrusion we got. We knew we really wouldn't see much mandibular change because Kimmy was basically done growing at that time for us. But there's our final results for this young lady. A little bit different situation as well. A lot of times people ask, do I have to have all the permanent teeth in? I know a lot of times in kids that I want to intrude and retract, maybe they don't have all of their permanent teeth in. So if we take a look at her cephalometric film, we can see we've got the class 2, the AP, class 2 relationship. We've got the AP change. Often I see, particularly in young ladies, that I feel like I need to start correcting that class 2 malocclusion while they're still growing. And if I'm waiting for the dentition to come in, I may miss that optimal growth time. So it's not uncommon for me to start when the lower arch is in. I'll align that lower arch, get into that rectangular wire, and instead of like last young lady you saw that had continuous arch, a lot of times you can just run that off of a 2x4. And what's really nice with this young lady as well is that we're going to retract those incisors and we're going to intrude them. So we've got that, we're going to have our forces in. We're going to place just a 2x4 in the top. We're going to put a stainless steel posted wire with that bite opening curve, and again, you can place NiTi coils as you're going. And I think if we take a look, there's our pre-forces ceph. We haven't worried about any class 2 correction. And we're going to go ahead and go after the bite opening with our forces in place. And I think what's interesting too, if you take a look at this young lady here, there's even more ways to work with the intrusion. If you look at where her springs are laying, in the first young lady, they were more horizontally placed. You can see with her, there is actually a bit of an angulation to those as well. So based on where you attach it in the anterior and where you place it in the posterior, not only can you have this curved wire, which you can see here working for you to intrude, you can also use this component, the vertical component of that spring as well. So just an efficient way to retract and intrude, and you can see the facial change that we're starting to make. And again, it's just really, really efficient and really easy. Once you get this set up and your patients come in and they look this way, go back to that last webinar. Just do ideal activations here, and watch when you get to the amount of bite opening that you want. Don't over intrude. I mean, sometimes you can forget and go too far. But when you get to a point like, boy, I like that incisor position, and maybe I still need some class 2 correction, we'll simply take out a curved arch and replace it with if it's a curved 19 by 25, if it's stainless or NiTi, we'll just take it out and put a non-curved or a flat arching, because you don't want to go too far, because that is a possibility as well. So just some different ways to go for the maxillary arch. So there's a couple questions that I did, again, need to go back, and I'm sorry I didn't get to all of them right away. Here's a good question. How do you cinch an upper NiTi? The easiest way I found to cinch a NiTi is you have to heat treat it. And very simply is what I'll do is I'll place the arch. You're going to leave a couple millimeters out the back. I take it out of the patient's mouth and I simply use a lighter. I know there's other types of heat treating things that are available, but a simple cigarette lighter works as well. Just have to be careful so you don't catch your gloves on fire and so you don't scare your patient. Once you see it turn brown or it turns a little bit of that blue color, it becomes dead soft. You can then slide it in. The thing I need to caution you when you're doing that, don't heat treat it too far, because then that wire will become soft and you don't want it coming, you don't want the soft part going through the tube. So that's the technique that I like to use. Obviously, if it's a beta wire, I can turn that, or a stainless steel. What size of upper wires do I like to have for the retraction, particularly in the one young lady, Kimmy, that we were talking about that had that posted. That was a 19 by 25 stainless steel that was posted. If you have a lot of torque in the maxillary incisors, you may even go 17 by 25 stainless. I think when you're looking at intruding the maxillary arch, I think there's couple things we look at. For me, my choices, I know I've got it, and I hate to make this sound too simple, and I apologize, but to me, I just think, okay, I need something with a curve in it. If I like the whole arch, and what I mean by that is that I don't want to retract it. I want to kind of keep the maxillary arch where it is, but intrude. And I don't have to create space in the arch. I don't have to retract the interiors. What I'll do is I'll go because for me it's so simple to use a reverse curved accentuated curved NiTi. Slide that in, heat treat it, and turn it, and I'm done with it. If I want to slide though, and I'm going to want to slide posterior, a lot of times I'm going to use a stainless, put some curve into that, and put some hooks on it. Because that way I can attach the springs from the molars to the hooks and just let those teeth slide forward. No, they won't slide forward. They slide posteriors, or they slide posterior where the molars hold their position. So you've got a lot of options in the maxillary arch, and sometimes we change back and forth, but usually it's a 19 by 25, either a steel wire that's got some curve in it, or a NiTi wire that I have heat treated. Let's see. Let me go grab a couple more of these here. Here we go. Where the health of the roots and maintained during the intrusion. And, that's one thing I think we all are concerned about when we intrude maxillary incisors, because I know I was taught, you don't want to use too much force, you're going to resorb the apex. But the interesting thing is that even with, when I put a forceps in place, you're not putting a lot of force in those maxillary incisors, or I'll be honest with you, before, a lot of times, if I was placing a reverse curve in someone like these last 3 young ladies and really needed to intrude their upper incisors, I was putting a lot of bite opening into it. Because remember, for every bit of intrusion I was getting from in the anterior, I was getting extrusion in the posterior. So I was having to put a lot more force. And to me, when I'm using it now forces, I'm not putting as much upper incisor force on those root apexes, because I don't need that much. Because remember, I'm negating the posterior. And a lot of times you can even start with some of these young ladies. We'll start with a 17 by 25, curved niti. And so we've been, I've been very fortunate that those upper incisors, I'll be honest with you, they look much better than maybe if you looked at some of my cases from 10 years ago when I didn't intrude with the forceps in place, and it was, if you think about it, I was swiping curve into stainless steel, trying to intrude incisors, then I was hanging class 2 elastics off those posted arches that were trying to extrude those anteriors. So I had a lot of force going there. This way, the only force really acting on the upper incisors, one is, obviously the wire intrusion, and then also those springs. Be careful when you're using springs to retract. Again, I use a smart clip bracket, so I'm in a self-ligated system. I don't have to use a lot of force to retract too. You want the lightest spring so that you don't want to over retract. You don't want it to happen too quickly. You don't want too much force on them. So, I'm comfortable doing it this way, and I think I see much nicer results than I did when I did it alone. Let me see. Let's keep going. You guys got some great questions. And again, if I don't get to all of them, what we'll do like we did last time is to go ahead and I'll answer every question. Then everybody will get the questions and all the answers. Here again, the question, are both mandibular or both arch wires cinched? In the lower, I always do, because I want to try to maintain that lower arch integrity and keep it as a unit. The maxillary arch, if I'm going to be retracting anteriors, I don't bother cinching it, because the wire is going to be sliding backwards anyhow. Oh, I know what I need to tell you. In a case like Kimmy or that other young lady, but particularly in someone like Kimmy who had a lot of anterior spacing, if you start retracting with the forces in place and all of a sudden it seems like they're not going anywhere, make sure you're not running into your second molar, because that wire will slide out the back, and it'll slide out the back really pretty quickly. If you're on your second molars and you're sliding through the second molars, make sure you're not impinging on tissue. If you're just at the first molar, make sure you're not running into the mesial portion of that second molar, or even if you're running into the tube, because I've had that happen before. Things are intruding, but they're not retracting. I look at them, the springs are still active, the niti coils are active, they're just not retracting, and then sure enough, I look in the back and the wire is bound up. It's hitting something in the posterior. So make sure that when you're seeing these kids that you're trying to retract and intrude, that you really keep an eye on those wires. And sometimes it's hard to see because you've got that forceps spring in there, but really watch that, so that can keep things moving. Here we go. Do you find chaining binds the curve into the arch versus tie back or bent ends? Chaining can create some binding. A lot of times when I'm in self-ligation and I want friction, I'll put a chain on there. So a lot of times too, we'll tie to avoid that. Lacing back is great because you can still keep things consolidated, and you're not really adding friction there. The other thing I found with chaining too is that if you chain the upper and you chain it 6 to 6 and you're in an easy 2 module and an occlusal tube, or an easy module and occlusal tube, that chain really pretty much stays intact for you. If you're using L pins, the rotation of that L pin tends to shred the tie that's going around the molar. So particularly if I'm using L-pins, if it's occlusal or gingival, I make sure that I cinch it or tie it back and try to stay away from the chain, because obviously when the chain breaks, the molar starts to distalize, and that might not be what you're looking for. Let's see, there's some other great questions here. Here we go. Why not use a segmented approach with the posterior segment, a TPA, and intrusive arch attached to the labial incisors? This will produce an anterior intrusion moment that is created until they'll move buccal. And I'm not sure if they're talking about, and I apologize, I probably should have read this more, using a segmented approach with a posterior segment and, transpalatal for an intrusion arch. Obviously if you can use transpalatal arches and intrusion arch, and you're right, a transpalatal arch can resist some of the movement that you would see if you didn't have it. Could you combine the transpalatal arch with the forces? I know some people that do that, and I don't. I myself don't. I think what's interesting too, if you're looking at a lot of cases that are maxillary protrusive, a lot of times, even though maybe the overpowering component of their malocclusion is their maxillary protrusive, but in a lot of these kids there's also a mandibular component as well. So if I'm going to place a transpalatal arch and just intrude and retract, I don't want to over-retract. Sometimes when people use a lot of distalizing appliances or, other types of that focus on the maxillary, it's easy to over-retract people. So even a lot of times in these kids that I'm looking at, I'm thinking, oh, it's your maxillary teeth, they need to go back. A lot of times if you look really close, they have a little bit of a mandibular deficiency too, if you're going to try to make up that whole difference. So what's fun about with the forces appliance is that you can intrude the maxillary teeth, you can retract them, and then when you think, okay, aesthetically, when you smile, I like where your front teeth are, and if you still have an overjet, well, guess what I can do? I can consolidate that maxillary arch, I can turn it up, or I can chain it, and then I can activate that forces to go after the remaining overjet that may be of mandibular origin, and then obtain a new mandibular position. So, it obviously is an option to intrude maxillary incisors using a bunch of different types of segmental approaches and, transpalatal arches. But what's fun is, if you get to a point and you think, now I want the mandible to come forward, you already have the mechanism in place, and all you need to do is kind of stop the top and then go for the bottom. So there's a lot of great questions, and we will answer them all, I promise. I'll try to do it quicker than last time too. So let's just kind of summarize things. So I think the main part that I really wanted to share is I used to waste a lot of time opening bites, either in the mandibular arch or the maxillary arch, and then I'd go after class 2. And then it finally dawned on me doing both at the same time. And there's some real advantages. One, you're doing both at the same time, so obviously it's quicker. But then when I started looking at the forces that were included, boy, that push rod really helped me in some of those kids that were deep. And again, don't be afraid to move it around. If you need to go anterior, if you need to change its location, you've already got the pieces there. Just go ahead and do it. And if you need, when you're looking at that class too, first determine, which arch do I need to intrude? And that's very simple. Just look at someone. Where's your smile? Do we need to move it up? Do we need to maintain it? So if we're going for that mandibular bite opening, determine, am I going to intrude the lower incisors? Do I want to extrude the posterior, or do I want to do both? And for me, part of that, I just kind of look at either their face from the side, compare it to the Ceph, and say, boy, do I like your lower face height? Are you proportional when I look at you? Those are obviously kids we want to intrude their lower incisors, because I've already established I like your smile, you've got a deep bite, it's coming from the bottom, your lower incisors need to be intruded. But what if I look at your Ceph or your lower face height? Those are the kids you kind of look at and you think that their nose and their chin just look too close together, particularly when you're 16. It's the old guy look or old lady look. Those kids, I'm thinking, boy, I really want to extrude your posterior teeth. And kids that are extreme, like that one case we looked at, you're going to have to go for both. I mean, you can't, if you've got a lot of movement, you can't expect it all from lower incisors. You can't expect it all from posterior extrusion. So what we're going to want to do is combine those both. So for incisor intrusion, put some bite opening into that mandibular arch. For posterior extrusion, you're going to do that after. You're going to take your forces out. Know you've got a posterior open bite. You expected it. Just run some baxo-elastics. And then for the maxillary arch, it's actually even easier. You're just going to intrude those maxillary incisors. Use a curved NiTi. Put some bite opening in stainless, and then consider using some NiTi coils. They're going to retract, and if you really put them at an angle, they may even help you intrude. So it just really helps. It's really versatile. It's really easy to use too. That's the best part, and I think you'll have a lot of. You'll find that you really have a lot of fun with it. I appreciate everybody's time today, and I almost said I'm so glad to see you, but once again I can't see you, which is really difficult to talk to. But I hope you join us again. Next time we're going to be talking about Class 2 correction in forces and extraction cases, which again is something that I've found really has helped me get the results that I want with a lot less hassle and stress for everybody. And I hope that you found today's information helpful. And again, I will get to the questions that we have, and that and some of the questions I'm seeing are related to some of the basic installations. So go back to the 3M Unitech website. In the previous webinar, there's really two. I think there's one on commonly asked questions, and there's one that's going to forces for beginners. If you go through that, that's going to give you a lot of the installation tips and setup that we use. There's also guides that 3M has put on there that are also the user. There's an installation guide that will help you with use too. So I appreciate your time, and I look forward to meeting with you again. Thank you.